Welcome, and thanks for joining our session today. My name is Stacy Olson, and I'm a certified professional coder with a specialty credential in evaluation and management services through the American Academy of Professional Coders. Today's online session is an introduction to medical billing and medical records. It will cover information that is relevant to billing for medical services. We will just scratch the surface of many of these topics today, but it should provide you with the basics of medical billing and documenting the services. CPT is the code set that is used to report professional medical services. The CPT codes are developed, maintained, and copyrighted by the American Medical Association. Every attempt has been made to provide you with accurate and current information, but the coding rules can and do change, and it is always the provider's responsibility to know the state and federal rules and to remain current on payer policy. Today's information is not legal advice or a reflection of any individual health system's policies or procedures. It is not instructing providers in the services they may perform and/or bill. It is simply meant to inform you of general knowledge and best practices for billing medical services and maintaining medical records. Our objectives in this session will be to identify the key factors for successful medical billing. We will discuss the code sets that are used for reporting medical professional services and their importance in the revenue cycle, and we will describe the importance of thorough medical record documentation. First, let's talk about the medical record. Medical records provide chronological documentation of services the patient has received. It records pertinent facts and findings about the patient's health and past history. Providers document their evaluation and treatment plans for the patient in the medical record, and it frames the patient's current and future care. Accurate medical records are critical to the patient's safety and streamlined quality care. Providers should make sure to thoroughly document all of the services rendered to a patient and the conditions being treated or evaluated. There is an old saying in the medical industry which is, if it isn't documented, it wasn't performed. So providers should always be very clear and concise when documenting services that were rendered to the patient. This will decrease the subjectivity of others when reviewing the documentation after the fact. Medical records should be accurately written, promptly completed and filed, and readily accessible. The medical record is used for patient care and as a method of communication between providers regarding the patient's care. But documentation may be requested by payers for prior authorization of services or to be reviewed to support the services reported on a claim prior to payment, and sometimes even after payment has been made. Keeping accurate medical records on every patient and safeguarding them are important responsibilities because they are also legal business records and must be maintained following federal and state regulations. There are general medical record principles that apply to professional medical services in all settings. Documentation should always be complete and legible. Each patient encounter should have a date of service, the reason for the encounter, relevant history and physical exam findings, any diagnostic testing that is relevant, the provider's clinical assessment and plan for the patient, and each note should be signed and dated by the provider. The recommendation is to document during the encounter or as soon as possible following the encounter to be as accurate as possible. A signature date and time or a note date and time does not suffice as a date of service because the note may be started at the time of the encounter but completed on a later date. If you are using an electronic health record, make sure that the EHR will populate an encounter date or date of service in the documentation. Or if you are using a transcription service to document the service, be sure to specifically state the date of service in your dictation. Medicare states that if the reason for performing a diagnostic test is not specifically stated, it should be easily inferred from the other content of the note. Past and present diagnoses should be available to all treating or consulting providers so that those providers have an accurate history to access. Appropriate health risks should always be identified, and the patient's progress, response to treatment, and any revision of conditions should also be documented. And of course, the documentation must support all of the billing codes that are reported on the claim form. Many providers use templates to document their services. The most common template format for documenting evaluation and management services in the past has been a SOAP format, which means that the subjective or history information is documented first in the note, followed by the objective information or physical exam, with the assessment and plan in the last section of the provider's note. This formatting is still used by many providers today, but more providers have started using what's called the APSO format. The APSO format lists the assessment and plan in the beginning of the note, followed by the history and physical exam. Many providers prefer the APSO note format because the bones of what a provider wants to know is generally listed in the assessment and plan of a progress note. While templates are an acceptable tool that providers may utilize, templates that pre-populate information are highly frowned upon by CMS. If the provider is using a template, the final document must be an accurate and individualized account of each patient encounter. Late entries, addendums, or corrections to a medical record are considered legitimate occurrences in documentation. A late entry would supply additional information that had been omitted from the original entry for some reason, and an addendum provides information that was not available at the time of the original entry. Late entries, addendums, or corrections to the medical record must bear the current date of that entry and be signed by the person making the addition or change. CMS states that total recall is necessary for late entries or addendums. If a late entry or an addendum was made several weeks or months after the service had been rendered, total recall may be very difficult to prove. A late entry should never be made to the medical record just to meet code criteria, as this could instigate accusations of fraud. An example of this would be that a provider submitted an E&M code which required 2 review of systems, but only 1 system review is documented in the progress note. Unless there is a paper form to back up that the review of systems was obtained on the date of service, I would not recommend making a late entry to the progress note. Some organizations still have patients fill out a paper health history form upon arrival at the clinic and will scan that form to the electronic medical record, in which case the provider would have documentation that the review of systems had been obtained on the date of service and that the provider had total recall for making the late entry. When making corrections in a medical record, providers should never write over or otherwise obliterate a passage in the medical record when an error has been made. Providers should draw a single line through the erroneous information, keeping the original entry legible. Since most providers use electronic health records now, the incorrect entry should be changed to a strike-through text. Providers should sign and date the deletion and state the reason the correction is being made, and then document the correct information on the next line or space with the current date and time, and reference the original entry. When a hard copy of the record is generated, both the electronic version and the paper version must show the correction. Any corrected record must be clear about the change, the date of the change, and the identity of the person who made the change. Medicare states that provider signatures need to be legible on medical records and orders. The signature should include the first and last name as well as the credential of the person writing the note or ordering the diagnostic test. Handwritten signatures are still acceptable, but if a record is not signed at the time of documentation or shortly after the service is performed, Medicare states to use an authentication process instead of adding a late signature to the medical record. Medicare does not allow pharmacists to be ordering providers for diagnostic testing. This slide shows us some examples of what Medicare considers to be acceptable or unacceptable signatures. It is not an all-inclusive list. The record must be clear that the provider has reviewed and is signing off on the documentation. Remember that by signing a note, a provider is attesting that the information is an accurate reflection of the service provided to the patient on that date of service. Medical billing is very different from pharmaceutical billing. There are a lot of working parts that need to move as a well-oiled machine to have a successful revenue cycle. This slide explains the patient encounter from the beginning to the end of the revenue cycle. The first step in medical billing happens when the patient initiates contact to seek the services of a provider for healthcare needs. An appointment is scheduled for the patient, and upon arrival for the appointment, the patient will be registered. The patient will be roomed and seen by the provider, and information from the encounter is entered into a billing system, at which point a claim is generated to the patient's health insurance carrier. The medical insurance will process the claim and generate an explanation of benefits that will explain the payment or reasons for denial. Information will need to be obtained from the patient and the provider of service for the medical claim that will be submitted to the medical insurance. You will want to get copies of the patient's insurance cards and verify the patient's identification. Insurance cards will provide the group number, the ID number, the subscriber information, claim submission address, and the payer's customer service numbers. Sometimes a patient may have more than one insurance, and the provider will need to determine the proper billing order. This is called coordination of benefits. In the case of more than one payer, the explanation of benefits from the primary payer will need to be sent to the secondary payer along with the bill so that the secondary payer may identify the balance to be paid. Some payers will automatically forward their explanation of benefits to the secondary payer if they are notified of who that secondary payer is. The patient should also sign a release stating that the provider can release their medical information for the purpose of payment, and the provider should have the patient assign benefits to them so that the payer may pay the provider of service directly. You will also want to inform the patient of their rights under HIPAA and have them sign an acknowledgement that they were informed of these rights. Providers will need a payer identification number for the payers that they are credentialed with. Providers will provide the date of service that the patient was seen, and they will also provide the reason that the patient was seen. The problems or conditions addressed during the encounter are reported on the claim form with ICD-10 codes, which we will discuss further in a few minutes. The provider will also assign the CPT or the HCPCS codes for the services and supplies that were rendered to the patient, which are also reported on the claim form, as well as the referring provider's name if applicable. The claim form will also require the billing entity to identify where the patient was seen, which is done with a 2-digit place of service code. I have listed out some of the more common place of service codes that I anticipate will be the locations where pharmacists will render services to their patients. There is a full list from CMS that can be found in the link provided on the reference sources slide at the end of this slide deck. There are also place of service codes for schools, prisons, homeless shelters, inpatient hospitals, and skilled nursing facilities, to name a few additional settings not listed on this slide. Your organization should make sure to identify the space services are rendered in and make sure to credential each location correctly. The place of service code is reported on each claim, and if the provider is practicing in multiple locations, each location will need to be added to the provider's credentialing profile with the payer. Credentialing is not really my area of expertise, so you will want to work with credentialing experts to get all of the information about the credentialing process. The International Classification of Diseases 10th Revision Clinical Modification, or ICD-10-CM, is the code set used to report why medical services were provided. It is maintained by the World Health Organization. ICD-10 updates each year on October 1st. The United States switched from ICD-9 to ICD-10 on October 1st, 2015. ICD-10 provides greater detail and granularity than ICD-9, and it enhances the capability to measure outcomes. You will want to make sure to get new books each year, or if you're using an encoder program, make sure that it includes updates each year. There were roughly 14,000 codes in ICD-9, and there are almost 70,000 in ICD-10, with a great deal of changes coming in October 2016. However, most providers tend to use just a small portion of the codes based on what they do. There are two versions of ICD-10, the clinical modification and ICD-10 PCS, which stands for Procedural Coding System. The PCS version is used by facilities to report the procedures performed at their facility. Medical professionals use CPT to report their services rendered to a patient. The clinical modification ICD-10 codes are used by everyone to report the conditions addressed during an encounter and to provide the medical necessity for the services that were rendered. ICD-10 has 21 chapters that are arranged based on body or organ system, or they might be grouped together by the etiology of disease. ICD-10 coding guidelines are in the books and will most likely be contained in encoder programs as well. These should be reviewed in depth for instructions on how to report certain conditions and for code sequencing instructions. Generally, the conditions reported by ICD-10 codes are documented in the assessment portion of a provider's note. ICD-10 CM codes will always start with a letter. They can be anywhere from 3 to 7 characters long. Some codes, such as the injury codes, may utilize a 7th alpha character to identify if the encounter is for initial or subsequent care, or if the encounter is related to a sequela of the original problem. On this slide, I have listed an example of what an ICD-10 code looks like. E10.621 reports a type 1 diabetic who also has a foot ulcer. As I mentioned, ICD-10 coding guidelines should be reviewed in detail, but some of the key rules for coding in ICD-10 is that providers should always code to the highest level of specificity for a patient's condition and report all conditions which were monitored, evaluated, assessed, or treated during the encounter. All of the ICD-10 CM codes that are reported on the claim form must be supported by documentation. Systematized Nomenclature of Medicine Clinical Terminology, or SNOMED-CT, is comprehensive clinical terminology that provides codes, terms, synonyms, and definitions which cover anatomy, diseases, findings, procedures, microorganisms, substances, etc. It enables providers and EMRs to communicate in a common language and increases the quality of patient care across many different provider specialties. It is owned by the International Health Terminology Standards Development Organization, or IHT-SDO. It is recognized throughout the United States and internationally and can be downloaded from the National Library of Medicine. SNOMED CT is essential for recording clinical data such as patient problem lists and family, medical, and social histories in electronic health records in a consistent and reproducible manner. It allows a consistent way to index, store, retrieve, and aggregate medical data across specialties and sites of care. SNOMED was designed as a comprehensive nomenclature of clinical medicine for the purpose of accurately storing and/or retrieving records of clinical care in human and veterinary medicine. SNOMED dictates that all records are identified by a globally unique number up to 18 digits in length, known as the SCTID. SNOMED is not used for medical billing purposes. It is translated or mapped to the most appropriate ICD-10 code, which is reported on the claim form. SNOMED concept codes are numerical codes that identify clinical terms, ranging from general to detailed, and they are organized in hierarchies. This allows clinical data to be recorded and later accessed or aggregated at a more general level. Descriptions link appropriate terms to concepts. Concepts can have several associated descriptions, each representing a synonym describing the same clinical concept. Relationships link concepts to other concepts whose meaning is related in some way. They provide formal definitions and other properties of the concept. Reference sets are used to group concepts or descriptions into sets, including reference sets and cross-maps to other classifications and standards, such as ICD-10. Under SB 5557, pharmacists do not have diagnosing authority for medical illnesses or injuries, so those ICD-10 codes must be obtained from the provider who is able to diagnose. SB 5557 recommendations state that pharmacists can assign codes from Chapter 21 of ICD-10-CM, which is titled Factors Influencing Health and Contact with Health Services. The codes in this chapter are known as Z codes because all of the codes begin with the letter Z. They are used when a person who may or may not be sick encounters health services for some specific purpose, such as to receive limited care, to receive vaccines, or to discuss a problem which in and of itself is not a disease or injury. This chapter also includes status codes for personal history or family history of medical conditions. On this slide, I have listed the ICD-10 code for administering immunizations, which is Z23. CPT codes describe the services that were provided to the patient. As I said earlier, CPT is developed, maintained, and copyrighted by the AMA. The codes are updated each year on January 1st, and I recommend obtaining new books each year to remain current with any code changes, or if using encoder software, make sure that it will include yearly updates automatically and that it will also provide you with all of the section notes that are contained in the CPT book. Usually the code updates for new, deleted, and revised codes are released in late fall, so you will be able to review them prior to their effective date of January 1st. Chapters are broken out by the type of service or organ system, and CPT codes always consist of 5 numbers. On this slide, we see the CPT code that reports administration of an immunization given through a percutaneous, intradermal, subcutaneous, or intramuscular route for one vaccine, whether it is a single toxoid or combination vaccine. Make sure to read the description of the CPT codes in full to report the code which is most reflective of the service that was provided. If there is not a CPT code that accurately describes the service performed, CPT does contain unlisted codes in each chapter or subsection for reporting these situations. CPT also includes two-digit modifiers which are appended to CPT codes for reporting additional information about the service provided. There are modifiers that will unbundle code edits when appropriate or give additional information about the service rendered. One of the modifiers that may be used by pharmacists is modifier 25. This modifier would be added to an evaluation and management CPT code when another service is performed on the same date. This tells the payer that the E&M is separately identifiable from the other services performed at that encounter. If it is not used, payers may deny the E&M code stating that it is bundled to the other service provided. This modifier should only be used when it is appropriate to do so. CPT contains Category 2 codes, which are referred to as F codes. These are used for reporting quality measures and are not billed with a fee. There is also a chapter titled Category 3 codes, which are known as T codes. These are temporary codes for emerging technology, services, and procedures that may one day develop into a standard CPT code. The Healthcare Common Procedure Coding System, also known as HCPCS, is a code set that is used to report supplies, drugs, devices, and a mishmash of other services that are not contained in CPT. This code set is maintained by CMS and is updated each year on January 1st. Again, you will want to make sure to stay current with any code changes. The HCPCS codes are structured to start with a letter and are followed by 4 numbers. You will find the codes to report medications in this code set, and I have listed the code J2315, which reports naltrexone, in depot form for 1 milligram. Many of the codes for medications state a dosage in the code description. If more than the dosage described by the code is administered to a patient, you would want to increase the number of units reported for that code to report the full dose administered. HCPCS also contains modifiers and reports such things as laterality. There are identifiers for each finger and toe. There are also modifiers for clinical trials and other pertinent information about the service rendered, and there are a lot of these modifiers in HCPCS. These are different from the modifiers contained in CPT and will be made of 2 alpha characters or an alpha numeric combination. A relative value unit, or RVU, is a numeric weighting that is assigned to CPT codes. However, not every CPT code has an RVU assigned to it. The total RVU, or TRVU, assigned to a code is comprised of 3 separate RVUs, which are the practice expense, shown as PRVU, the malpractice portion, shown as MRVU, and the work RVU, which is shown on the slide as WRVU. The RVUs are used by healthcare providers to determine their fees by multiplying the RVU by a monetary conversion factor they deem appropriate based on the market in the area that the service is performed. Payers will also use RVUs to determine their allowable fees for CPT codes. And some providers are compensated based on how many work RVUs they generate, which can directly impact their paychecks. RVUs are part of RBRVS, which stands for Resource-Based Relative Value Scale. This is effectively copyrighted by the AMA, but its use is required by statute for CMS payments. This was signed into law in 1989, which switched Medicare to an RBRVS payment schedule effective January 1st, 1992. RVUs are also updated yearly, but not every code will have a change from year to year. Organizations will want to review the RVUs yearly to determine if any updates to their fee schedules are necessary. Medical necessity should always be the determining factor in what services a patient receives and is used as the basis for reimbursement by payers. Documentation should be in the medical record to support all of the ICD-10, CPT, and HCPCS codes reported on a claim form, and the volume of documentation alone does not mean that the services are supported. Providers should make sure to record information that is relevant to the specific patient encounter and addresses the complexity of the service provided to the patient. It should contain a detailed, real-time record of the patient's responses, exam findings, the problems addressed, and the treatment plan for each problem. Providers are responsible for the services that are reported on the claim form. Qualified coding and billing staff can review documentation and help select codes for the service, but providers do bear the responsibility for the services they report. Payers may have policies for services that require certain clinical criteria to be met and will instruct providers in what ICD-10, CPT, and HCPCS codes pertain to that policy. Medicare, for example, has very specific policies. They have National Coverage Determinations, or NCDs, and some of the Medicare Administrative Contractors, or MACs, will also have local coverage determinations known as LCDs. Check the payer websites regularly for updates to their medical policies and procedures. Many of them now have email updates that you can sign up for, so it is always a good idea to be on the payer's direct mailing list. Each CPT code reported will require at least one associated ICD-10 code telling the payer why you performed that service. National Correct Coding Edits, or NCCI, were developed by CMS to promote national correct coding methodologies and to control improper coding. They are based on coding conventions in CPT, Medicare's national and local policies, national societies, and the standards of medical and surgical practices. NCCI is maintained by CMS, but many commercial payers utilize these edits for correct payment of claims as well. The NCCI manual is updated annually on January 1st, but the edits themselves are reviewed quarterly and may be revised. Sometimes an edit will be contested and then retracted, and sometimes that change is retroactive to the time the edit was originally put into place. In these cases, claims may have to be resubmitted for payment, and at other times the payers may perform a mass adjustment for the codes that previously denied due to an NCCI edit that has been overturned. NCCI contains two types of edits. The procedure-to-procedure edits prevent improper payment of codes that should not be reported together due to inherent or overlapping work and were implemented in 1996. Sometimes modifiers can be used to bypass these edits when appropriate, and Medicare includes indicators on these edit tables to let us know if the edit can be bypassed. Sometimes they just can't be bypassed regardless of what modifier is appended to the CPT code. Medically unlikely edits were implemented in 2007 and limit the number of units that can be reported for certain CPT codes on a given date of service. Here are my sources for this session. I recommend that you read them for yourselves for a thorough understanding of the guidelines. If you work for a healthcare organization and have a coding educator available to meet with you, I would encourage you to do so to understand the organization's policies and procedures regarding medical billing and record documentation. Thank you for listening to our session on medical billing and records. I hope that you now have a good understanding of how to document the medical services you will render and how important the clinical information you document is for billing, payment, and legal purposes.